First, for now, we're moving straight to the plenary session, and we have Dr. Ifedayo, Adetifa, Director General, Nigeria Center for Disease Control. The keynote lecture is on infectious disease preparedness and response, challenges and prospects in resource-constrained settings. And I'll be taking his citation now.
Yeah, I haven't been listening, but
I'm taking his citation first. Thank you. If we can have his photograph, thank you. Do we have his photograph on the screen? All right, thank you. Dr. Ifedayo identifies the Director General of the Nigeria Center for Disease Control and Prevention, NCDC. Dr. Adetifa is a pediatrician and epidemiologist whose work has covered areas of pediatrics, HIV/AIDS, tuberculosis, and vaccine-preventable diseases epidemiology. Mr. Ifedayo Adetifa received his undergraduate medical training at the University of Ilorin and completed his residency training in pediatrics at the Lagos University Teaching Hospital. He then proceeded to the London School of Hygiene and Tropical Medicine, where he obtained an MSc in epidemiology. He also has a PhD in epidemiology from the University of Amsterdam. He has focused on vaccine epidemiology research with a focus on evidence generation for vaccine policy in Africa through vaccine impact studies and seroepidemiology. He was a member of the Kenya SARS-CoV-2 Serology Consortium and is a member of the World Health Organization African Region, Regional Immunization Technical Advisory Group, the WHO Respiratory Syncytial Virus Technical Advisory Group, and the Program Advisory Group for the Malaria Vaccine Implementation Program. Prior to leading the NCDC, he was an associate professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine and clinical epidemiologist at the Kenya Medical Research Institute, Wellcome Trust Research Program, and prior a clinical epidemiologist at the Medical Research Council. Units in the Gambia. Now, on the day he was taken over as Director General of the Nigerian Center for Disease Control, his predecessor, Dr. Chikwe Ihekweazu, had this to say about him, and I quote, "During this time of transformation, there is no better person to lead our young agency. Dr. Adetifa is a proven leader with strong epidemiology, academic, and research background, as well as the ability to bring people together." Distinguished ladies and gentlemen, I present to you the Director General of the NCDC for the keynote lecture. Please put your hands together for him.
Good afternoon, the distinguished audience, the members of the Board of Trustees of the Nigerian Infectious Disease Society, the President and other executives, and the members of the local organizing committee, and of course the distinguished audience. And thank you very much for your kind words and for that detailed introduction. It is indeed a privilege to have been asked to speak at this meeting. I apologize for not being physically present. I've got conflicting commitments, and indeed would have to leave for some other official engagement in about 20 minutes. But it is a pleasure to be here, however limited the time I have to spend it. And it's been a delight to listen to the as much of the first scientific session as I could listen to, and to also see and hear from some of our very senior colleagues, including the first chief executive of the Nigeria Center for Disease Control and Prevention, Professor Abdulsalami Nasiri. Thank you all very much for your time and for the opportunity to say a few words at this time.
Good morning, distinguished senior colleagues, and guests, ladies and gentlemen. Permit me to stand on the established protocol. Thank you very much to the organizers, the Nigeria Infectious Disease Society, for inviting me to speak at this event, which is this occasion is the 10th annual General Scientific Meeting of this illustrious professional body. I have been asked to speak on the topic infectious disease preparedness and response, challenges and prospects in resource-constrained settings. By now, with the lofty citation, everybody knows who I am, and I'm grateful for the kind words that of introduction that were made earlier. So obviously, we'll be speaking about resource-constrained settings, but because Nigeria, we are a Nigeria Infectious Disease Society, and this is the Nigeria Center for Disease Control and Prevention. A lot of the examples and a lot of the applications we'll be talking about are drawn from Nigerian examples and our context. So, why is this an important subject? Well, this is a map of the world juxtaposed with some newspaper headlines that show basically that worldwide, and when you look at our continent in particular, we are under siege by various pathogens. We are indeed just battling to keep up defenses, to keep up the drawbridges and all of the other defenses that we have in place to prevent these pathogens from taking over. And who can blame the pathogens? After all, it's a matter of survival for them as well. Just as we are hustling to get by and do all the things that are necessary for our survival, all these pathogens want to do is live in peace, reproduce, have babies and grandbabies and great-grandbabies, as the case may be. This was a very interesting newspaper, a news magazine headline that was released as an issue that came out a few years before we even knew there would be a coronavirus pandemic. And the headline bore or carried a stark warning about how the world was not ready for the next pandemic. And actually, as the audience would know, when the world was talking about the next pandemic, we were actually preparing for a flu pandemic. Never in the history of the world had there been a coronavirus pandemic, but we have had flu pandemics, and indeed it was a flu pandemic that was being expected when we were hit out of nowhere by a coronavirus pandemic, which we can't still speak about in past tense because this is still an ongoing problem, an ongoing issue for many parts of the world, despite the significant progress that has been made in the response, especially with the development of vaccines and therapeutics. We are in our setting and similar setting dealing with the challenge of emerging and re-emerging diseases. And as you all know, emerging diseases are those that we previously didn't know about, that have emerged to become public health problems. And of course, the re-emerging infectious diseases were those that were previously of public health concern or constituted public health threats, but disappeared and only returned again to causes havoc. And some of the factors that are involved in the emergence of infectious diseases are as described. So human susceptibility to infection. I'm just going to touch on a few. Changing ecosystems, climate and weather. Of course, the big part of that is our human demographics, population increase, and our behavior in the environment. International travel and commerce, breakdown of public health safety measures, lack of political will, war, famine, poverty, and social inequality. And these are characteristics of resource-constrained settings, including ours. So we can understand how the presence of this, we know in Egypt at the COP meeting, the rich countries have just agreed to put together a financing package for countries like ours who, though they contribute less to climate damage to the climate, at very high risk of disproportionately being affected by the consequences, as we've seen with floods recently, the drought in parts of Eastern Africa and Horn of Africa, and increasing temperatures, adverse weather, and all of the like, which sort of means that we should continue to expect pathogens to re-emerge or new pathogens to emerge. So imagine diseases like COVID-19, can there be major threats? And we imagine diseases like monkeypox can become public health emergencies of international concern. Indeed, we are quite concerned at the Nigeria Center for Disease Control and Prevention about what the impact of climate change may be to some conditions that we consider climate sensitive. So Lassa fever, yellow fever, and malaria, because increasingly wet and warm climates will lead to proliferation of the vectors that aid the transmission of these pathogens. And therefore, it's projected that we will be at an increased risk of all of these conditions that are considered climate sensitive. So let's talk a bit about some particular conditions. So this trend map or graph shows what's happened with Lassa fever from 2018 to 2022. As I said, actually the 2020 outbreak is the sort of largest outbreak in terms of the peak that was reached. But we are quite worried about 2022, which, although it's not reached this peak, it has peaked a few times, but more importantly, the trend line has stayed really above the lower limits we tend to see for most of the year. And of course, now we are beginning to see it trend up as we enter the malaria, the Lassa fever season. At the same time, we are having to deal with what is the largest monkeypox outbreak since monkeypox first re-emerged in 2017. So this, I don't know if you're colorblind like me, let's just say some shade of yellow line shows monkeypox cases for 2022. And you can see how significantly different this is compared to the preceding 5 years. So we're having to deal with monkeypox. That's not going away. We are having to deal with Lassa fever, which is now approaching the period when there's seasonal exacerbation. And along with that, there's still COVID in the background. Thankfully, we're not seeing any more deaths, but we're still seeing a few cases, even with the reduced testing that we have across board. So we might think COVID is gone or it's not a problem, but the point is, as the virus continues to be transmitted through the community, we are seeing new variants emerge. Of course, we all know that only 4 variants of concern have been identified in Nigeria. So the Alpha variant, the Beta variant, Delta, and Omicron, which arrived approximately the same time last year. But Omicron has taken over and is by far the most dominant variant in Nigeria from our genomic sequencing work. And we still see a bit of Delta, but what's happening is Omicron is having babies, or the family, the extended family is becoming larger. So now we're talking about the BQ1 variant, including its sublineages, BQ1 which the European CDC is tracking this as a variant of interest. And it's projected that most, at least 80% of SARS-CoV-2 cases are likely to be made up of this new sublineage. So in Nigeria, I've only put the figures for September and October, but if I recall correctly, I think we may have started seeing some of this in August, but we are seeing all of these Omicron babies, BQ1, BQ1.1, in the country as well. So despite the disconnects between case numbers, severe disease hospitalization and death, this pathogen is still doing what it's doing in the background. And we are basically, without being adequately vaccinated or having enough protection through a combination of natural infection and vaccination, we run the risk that as transmission continues to occur, things may align in such a way that we actually have a variant that will escape this heterologous immunity that hopefully most of us currently have. So in response to all of this, what's the country been doing? So Nigeria, like many other countries in the world, resource constrained or resource rich, is a signatory to the IHR 2005. IHR, the International Health Regulations, basically provide a framework for countries to assess their abilities to detect, assess, notify, and respond to public health threats. And more importantly, to look at the technical areas or standards that countries are meant to attain to be able to do this correctly. So Nigeria's carried out a joint external evaluation, which is sort of an evaluation of a country's readiness to respond to outbreaks of international concern. And we scored 39% in 2017, and following further investments in the health security space and the midterm review, that score moved up to 46% in 2019. What is not immediately obvious is that the components of the areas assessed that we recorded the most growth was in terms of response. So because we obviously had to contend with many concurrent public health threats, and we did quite well in mounting a response, but our preparedness indices did not change. And the investments you do in peacetime, which where you don't have to respond to a pathogen or preparedness as it's called, are often cheaper, they contribute to resilience, and they go much further in terms of protecting the country and citizens from public health threats. So we also came up with a national action plan for health security, which is not just a health matter. So it requires, the action plan requires multiple agencies, multiple sectors, and basically we took a whole of a government approach to come up, design that strategic roadmap and in its implementation. In addition, the signing into law of the acts that established the NCDC represented for this government one of the most important efforts taken towards preparedness against infectious disease outbreaks in the country. So let's just talk a bit about the NCDC, which I'm sure everybody knows about. Basically, this is our mandate, so I'm not going to spend too much time on it. It's to prevent. People tend to forget the prevention part. They're always focused on the control or response to after things have happened, but it's to prevent, detect, and control the spread of communicable diseases. And we do that. Our mandate is fulfilled through a number of key interventions, so surveillance systems, public health laboratories, health research to inform policy, and of course, the coordination of the country's compliance with our obligations under the international health regulations. So, in terms of our response to outbreaks, this is what happens. You collect and collate data, laboratory confirmation and advanced diagnosis, rapid response teams are sent to support state-level response, Of course, then we take all of the lessons learned from that and develop disease guidelines and protocols for response. And of course, we maintain a supply of items that are needed, medical and non-medical countermeasures, and in vitro diagnostics that are required for all of this as a backstop to all of these activities. What Nigeria has is this model. So when you have a national public health institute such as ours, what happens is that all of these domains which are necessary for preparedness and response are actually under one roof. So this makes for synergies, it makes for efficiency, it makes for streamlined coordination, and puts countries at a better place to make much more progress in their preparedness and response activities. So again, this just covers what we do: emergency response coordination, case management and infection prevention and control, obviously in collaboration with the Ministry of Health, Hospital Services Division, and other stakeholders. So let's look at some of what has happened in the context of responding to outbreaks. So before COVID arrived, you can see there were only 5 locations sort of where we had molecular laboratory capacity. And these were actually because we had a lab network that had been previously set up to look after Lassa fever. But post-2020, as part of the investments from COVID, we are now at a situation where there's at least a molecular lab in all 37 states, where 36 states plus the federal capital. And of course, in many locations, there's more than one. And I'm talking in the public service, so both state governments and in federal government institutions. Of course, we know there's a lot of private laboratories as well. Prior to 2020, we had only 17 states where our digital surveillance management platform called SOMAS had been deployed as part of efforts to move away from paper-based surveillance to something digital that can give you real-life figures. And of course, the impetus to move from paper to digital was actually started with the reemergence with monkeypox, or started with Ebola, was further shot in the arm with monkeypox coming up, and then with Lassa fever and others, we continue to expand. And of course, with COVID's final push, all states have SOMAS deployed. All local governments have SOMAS deployed. And the next area of growth for us is to ensure that all health facilities, or all qualified health facilities and labs actually have SOMAS deployed. And this is both in the public and the private sector, so that we have one cohesive unit, one surveillance unit that helps us to again detect conditions so that it can be reported in time for adequate and prompt response. Enhancing emergency preparedness and response. Emergency operations centers, called EOCs, are essential platforms for the operations of any emergency response in states. Prior to 2020, these were present in 29 of 37 states, and a lot of them, especially all of these ones in green, were driven by activities that were put in place to, as part of the global plan to eradicate polio, the Global Polio Eradication Initiative. As at post-2020, all states now had PHEOCs. At this time, we were saying except Jigawa, but I'm pleased to announce that the Jigawa EOC has been sorted out and is just awaiting formal commissioning when dates can be fixed. So, what are the common challenges and prospects to the infectious diseases outbreak response in resource-constrained settings? Well, some of the key limitations to, or the key impediments to the ability of public healthcare systems in resource-constrained settings to effectively prepare and respond to infectious disease outbreaks are as listed. So, healthcare funding, diagnostic capacity, political instability, insecurity, personnel shortage, supply chain challenges, And this is not an exhaustive list, but this I'm sure we can all relate to. And these are challenges at national level and indeed at subnational, state, and local government levels. So again, I'm going to highlight climate change as another challenge, which we are not paying enough attention to, but the key source of worry, climate change, is the increased vulnerability it confers on populations. And this vulnerability manifests through what is described as climate-sensitive health risks. So if we focus on the health-related challenges that might come from climate change, so you have heat-related illnesses, respiratory illnesses, waterborne and other water-related health conditions, zoonosis. So if you're thinking zoonosis, just think about monkeypox, Lassa fever, Ebola, Marburg, yellow fever, Lassa fever, even COVID. So all of these 6-7 diseases I've mentioned have something in common. They are all zoonosis. And the projections for the world is that we will continue, and increasingly so, be at risk of outbreaks and public health threats as a result of zoonotic pathogens. Same thing with vector-borne diseases. And even, although we're talking about infectious diseases, even non-communicable diseases will have an elevated risk as a result of climate change, and things like malnutrition and other foodborne diseases. So, preparing for future health challenges and then the lessons and the opportunities. So I thought I would start off by a reflection on the effect of the disease epidemics when we're talking about COVID or all of the other concurrent challenges that we have to deal with. A few things stand out. It's not NCDC's business alone. It's not Federal Ministry of Health's business alone. Partnerships are essential and they are valuable, even as we think about how to build effective public health response to public health challenges. The human beings, perhaps even more than the buildings, more than the equipment, more than the transport, more than the consumables, it's essential that we invest in human capital, to invest in the human workforce capacity that is required to ensure that we have a resilient health system, resilience in terms of our ability to bounce back from any public health threats. It's essential that we continue to work on effective surveillance systems and that we sustain all of the laboratory capacity, especially in the context of all the COVID-related investments. We now have to face the challenge of a good challenge of how do you wield all of these new laboratories into one cohesive public health laboratory network. Nigeria may not be the biggest country in terms of land area, but we do have challenges with road travel, with air travel, even with trains. And all of this come together to highlight the challenge or the importance of ensuring that we have availability of medical supplies right down to the last mile. So to that health post in my village, in my ward, in your ward, or your village, on that creek, on that little island where it is required, either as a vaccine to prevent something or as a diagnostic to confirm diagnosis of something as well. We need an all of the population approach. So certainly we need to have trust with the public through transparency and open and timely, prompt, appropriate communication. Again, we need sustained health security financing. A situation where you go from starvation to gluts of funding in the context of a response mode where, people have a tunnel vision for what needs to be done to bring up an outbreak under control. it makes for a more expensive investment and one that is less likely to go as far as if little building blocks in the background during peacetime were always being added to the architecture of our health system. This is not just national level, because we know that in this country, we will only be as strong as our weakest link. So if one state is not functioning properly, any problem that occurs in that state will ultimately become a problem for the rest of the country. And the same thing we see in the rest of the world, that if you ignore something going on in some part of the world because you think it's too far away from you, the lesson and the evidence is that that condition will eventually find its way to you. Sooner, if not sooner, it would arrive later. So we need to strengthen our subnational health security in addition to sustain health security finances. So national governments need to put down financing, subnational governments need to put down financing, and we need to also take better control of our destiny by ensuring that we keep on top of research and development that is required to solve especially our society's needs for particular infectious diseases. And it's, we also recognize as a final reflection the importance of political commitments to building resilient health systems. So we need functioning primary health care, we need universal health coverage, we need health insurance to work. You might ask me, what's the connection between those and health security? Every health security threat starts in the community. People have to be able to present promptly to a health facility, to have the correct diagnosis made as part of efforts to ensure that they receive the right treatment. And this diagnosis, if it's notified or if it's suspicious, a process for escalating that onwards so that it attracts the necessary response for the investigation and an effective response. So I've said a lot about not ensuring that we don't invest only in the context of a crisis. So it is essential that we invest in transforming our primary healthcare into a resilient and sustainable healthcare platform. So it is good to see the federal government's renewed commitment to revitalizing primary healthcare centers. The gulf, the deficits, or the damage that has been done is significant. So there's a long way to go to bring back primary healthcare to where it's supposed to be. But it is an essential bit of investment that needs to be done, because that is the source and will be the source of resilience and sustainability. It's the platform on which everything else is expected to rest. And certainly we need to do more in terms of strengthening the capacity of human resources in our healthcare facilities. How do you boost morale? How do you ensure people are adequately trained to know what they're supposed to do, ensure that they have opportunities and the like. Of course, I've talked about allocating increased funding for epidemic preparedness at national and subnational level. And we need to make sure that every player, from the community right up to the highest level of the healthcare, understand that surveillance activities are not extra. They are not research. They are not special duties. They are part of our normal function. And we must all recognize the roles that we have to play in ensuring that events or cases are detected, are reported, are escalated, and attract necessary response. I'm connected to that because I am speaking to an audience at the annual general and scientific meeting of the Nigerian Infectious Disease Society. Is what is infectious disease practice without diagnostics? How do we manage bloodstream infections, other invasive pathogens without having accessible or democratized access to blood cultures, for example? How do we do that without having aspirations to use our molecular biology labs for testing that is beyond HIV. For many of us, was the one that brought enlightenment in terms of molecular biology or molecular biology techniques, PCR and the like, for viral loads and for early infant diagnosis and the likes. And then we now know about these platforms in the context of all these epidemic and epidemic-prone conditions. But we should be thinking about what applications that they can be brought to bear, or that can be, how they can be extended to supporting clinical care. What tests, what other tests do we need to do to contribute to clinical care? Even if it's on a pilot or preliminary basis to gather data, but we have to do better with diagnostics and do better with diagnostics and adhering and following standard protocols. So, as the Nigerian Center for Disease Control and Prevention, what are some of our priorities and opportunities in the health security arena? Certainly, we want to have really strong One Health collaborations, not just in Abuja, but all the way down to the community. So this is recognizing that human health is connected to animal health, and health of animals and humans is irretrievably connected to the environments that they both share. We need to have one public health emergency operations center for all diseases of public health importance. So we don't want fragmentation by disease. We don't want fragmentation by whether it's infectious or non-communicable diseases. It's, the PHEOC should have as operations platform for responding to all public health threats, or anything that's considered a public health threat. It might even not be a disease, it might be poisoning, it might be mass casualty events, or even flooding and all the natural disasters and all of that. We are committed to doing more at subnational level in terms of coordination. So we will have regional centers and labs. We will focus a bit more on supporting and strengthening, helping states strengthen what they do. I've said a lot about public health workforce development, but believe it or not, the attrition in the public health workforce does not only happen in hospitals, it also happens even at the NCDC. We need to have one surveillance system down to the community. Okay, so SOMAS, our surveillance outbreak response management and analytical system, is presently in hospitals, in health, qualifying health centers, and its digital platform. We have done work now to make sure that it is interoperable and can speak to the surveillance platform for animal health, can ultimately or will ultimately be able to speak to whatever environmental health surveillance system is developed. And all of this can feed into the DHIS2, which is the national sort of health systems, health information management system. But we need now, as we are doing in pilot, to build on community surveillance that was previously successfully used for polio eradication as a means to also look after all of the other conditions that we are worried about. We certainly need now, in addition to wielding all of our laboratories into one cohesive network, we need to have unified biosafety, biosecurity, and biorisk protocols and documentations for all of these labs. Resource mobilization is something that we can't do about. Of course, we need to, not just by ourselves, but in collaboration, but also in working with societies such as yours, or commissioning societies such as yours. We need to improve our public health research capacity to generate the evidence that is required to inform preparedness and response. And of course, we need to get better at not just waiting for things to happen, but to have sentinel surveillance, or the ability to forecast and to make predictions, so to model things that are coming by scanning the horizon and doing the necessary computational work to help us prepare better and help us also respond better to these challenges when they occur. So I'm just getting to the end now. Let's talk about lessons and gains from resource constraint settings in the aftermath of COVID. So this is a long title for, what are the opportunities there to carry forward some of the gains from the COVID pandemic. So we really should stop working in silos, okay? There's this whole thing about, oh, this is my area, I'm an infectious disease specialist, all of this is my area, or, I'm a cardiologist, or I'm a parasitologist, I'm a bacteriologist, virologist, and all of that, but we need to stop working in silos. There are commonalities, and the commonalities do not preclude specialization. But specialization does not mean that you become so rarefied that you do not interact with the rest of the world. Your patient comes from a community, from within a set of people. And somehow, while there's always that argument about how maybe public health, people with the public health approach do not see one tree, or they see a forest, or see people, and the people in the clinicians in the hospital are interested in one patient. Well, in terms of public health, everybody has to find a middle ground. Your one patient, even as clinicians, what we are taught is you must always think about where the patient comes from, because whatever you are seeing is significantly contributed to by the shared environment, shared space, a shared ecosystem that individual patient has come from. Of course, national health security is now a sexy term that everybody repeats or reports. We hope that with the increased awareness of what it is, it will also make sure it's prioritized, and not just prioritized in talk, but that we will walk that talk. COVID-19 should see the end of not harnessing the value of technology. It should see the end of any paper-based surveillance system, because they are just not useful for real-time, to provide the real-time information that you need. It definitely has seen the end of sparse in-country molecular diagnostic capacity. And it has seen the end of poor investments in communicative science to the public. Only catch to that is that communication needs to really go down right into the community level, investing in appropriate land communication in the people's mother tongue and their languages, and not just sort of conversational language, but being able to bring science down to the easily digestible tidbits in the local language for the public. And hopefully in the aftermath of COVID-19, we will see further, we've seen the beginning already, but we want to see gains. We want to see it become an established habit and not one that we just forget about as COVID goes away. We hopefully will see more multi-sectoral collaborations towards strengthening health security. Members of the Nigeria Infectious Disease Society will work closely with the Nigerian Society for Pediatric Infectious Diseases. Internal medicine or adult physicians will work better with pediatricians, and all of us will work better with veterinary, our colleagues in veterinary science, veterinary medicine, and even our colleagues that we might look down upon in the environment. So all those environmental health officers are important. Health security will remain a priority of the national and global health agenda. We will, working together, sustain our molecular laboratory diagnostic capacity by not only focusing on them for purposes of response, but to also wield them as tools into preparedness, but also to feed into a cascade of clinical care. So what role can you and I play? Well, we have to work together. There is no public health without the support of the community. There is no infectious disease response without the support of the community. And the community is everybody. Scientists, doctors, nurses, everybody, okay? And everybody has value. Everybody has knowledge and experience to bring that should not be discounted. We need to build and continue to build in-country public health expertise. And again, to remember that surveillance starts with the correct diagnosis for that patient, that index case who, as at the time is presenting to the health center or to the dispensary or to the health post, we do not know yet that that's patient 0. And the only way we can know, if we can be sure, make sure that we always are able to identify patient 0 in a timely manner, is to ensure that we apply standards, evidence-based medicine. We generate all of that data and move it on forward so that that data informs the necessary actions. And of course, this is a society of infectious disease experts, lots of professors and academics. So please, it's important to write down the narratives of this journey into effective infectious disease response, outbreak response, and to share that widely, both as a form to provide for South-South collaboration with other countries that are further behind, but also to document this for posterity so that when our successors are trying to understand why they're looking at whatever it is they're looking at the time, they can see evidence of how the system evolved and how the situation came about. And I think that's my last slide. So again, permit me to thank you all very much, the organizers especially, for inviting me to be part of this meeting, and to such wonderful, distinguished audience for listening to me. Thank you very much.